Nice to meet you all. My name is 정재훈. I work at Gachon University. So it's so good to do a lecture when translation is provided. I always debate over whether I should deliver my presentation in English, but today I will opt in for translation, so I will be delivering my presentation in Korean to make sure that the information is accurately delivered to highlight the situation in Korea. So taking this opportunity, I would like to talk about the relationship and the importance of COVID-19 and data science. So I would like to give you an overall picture of the association. So I would like to make some announcements. So I have many different positions working with the government, but this presentation is based on individual opinion. And the forecasting model is sponsored by the Ministry of Science, ITC, supervised by National IT Industry Promotion Agency, and I do not work alone. I work with many of my distinguished fellows and colleagues. I would like to thank Dr. Jung Song-mok at Johns Hopkins and Dr. Young-ji Cho as well. So I have been working as an epidemiological investigator more so in recent years. So in the past, the phenomenon has been predicted based on data. So it sounds very fancy, but we do a lot of groundwork. So in order to accumulate data, we need to make sure to meet a lot of people, and a lot of sweat and perspiration goes in. So this is a picture of an ordinary life as an epidemiological investigator. So many of our Army service members are losing their lives to infectious disease. So I'm trying to commit my work to make sure that we know better about the epidemiological situation so that we could provide a response in a timely manner. So this is a HERA symposium, so I would like to highlight the claim data. So claim data in relation to researches, when we do so, we need to think of how much the claim data could reflect the situation of the infectious disease. So claim data is challenged in terms of the accuracy and so on. So KCDC's report data, compared to that, we need to identify the data in terms of studying infectious disease in relation to claim data. So we have a good system and the reporting rate has went up, but if you look at the next slide, the bar chart is the reported cases and the red line is claim data. So in the case of Korea, before the MERS period, the infectious disease reporting was not mandatory. Thus, reporting was not implemented or done a lot at all. So if we are to talk about claim data, some infectious disease looks like it's under control, but if we look at the report data, it seems like the infectious disease is rapidly on the rise. So among report data and claim data, what should we trust? So there's a lot of controversy over this question, but in terms of the past data, I think the claim data is very meaningful. So what you see on the slide is the ratio comparison of the report data and the claim data. MERS hit Korea as well, and post and pre to MERS, the reporting mandatory or the mandate has been changed. So now, in recent times, the report data and the claim data is much more. In the past, the claim data was high compared to the report cases. So in terms of, or for the long-term trend, the claims data would be more accurate, according to my analysis. So if we are to use claim data, utilize it, it could be used in many different ways. As you can see from the slide, this is a trend about varicella. So the red is the claim data and the blue is the report data. And you can see that there are two interpretations. According to the report data, it looks like the varicella is on the rise in Korea, but in terms of claims data, it looks like varicella is under control. So there are two different trends. What should we trust? So this is subject to controversy and different opinions, but if there are economic incentives and if this leads to claims data, I think it's more accurate to read the overall trend in a more stable manner because there's an economic incentive for claims data. So we look at the data and we also looked at the cumulative data based on age. The claim data is more of quality compared to the report data. So in terms of infectious data analysis, I think using claim data is an okay choice. And in most of the nations, the claims data nationwide and the national database has been established, and this is giving way to unimaginable researches. So many people think before COVID-19, the infectious disease issue was if the influenza is caught by one patient and a Tamiflu is taken, there were many rumors that it would have adverse risks. So that undermined the immunization of Tamiflu. That's why we did a comparison of the ones who taken the Tamiflu and did not take in the Tamiflu to have scientific evidence. So claim data is a nationwide, national level data, and that's why these kind of researches are possible. So claims data has been worked on in many different methodologies, but we need to think of the utilization and the operational method. So in recent times, for pharmaceuticals, more than 20 has been published, and it also covers underlying conditions and also the recent trends. And by doing so, we will have more stable results. And as you all know, claims data is based on diagnosis codes to define events. So we need to also think of how reliable the definition of the events are. And we also need to put in efforts to complement the operational definition. And I will skip some slides. And if you look at big data's suicidal attempt is less than 1 from 100,000. And if we look at the risk period after the Tamiflu, the incidence rate is very low. But we are able to look at nationwide data, and the adverse events happen in very rare cases. So this is what we are able to know from the claims data. And the claims data have been started to be merged with other different data. For instance, with the meteorological events and individual identification information as well. So before COVID-19, we also looked at the meteorological effects and factors as well to see if the meteorological factors affect a virus. As you can see from the slide, the address information is present for claims benefits. So based on that, we are able to identify the impact of the weather and weather conditions as well. So this has been part of our early studies. So many different kind of approaches are possible in case control and cohort studies, and also economical and pragmatic researches or methodologies are being used. And by doing so, if there is a condition, there are many different meteorological factors, for instance, air pollution, and so on. So we are able to look at the correlation between these factors. Just because the claim data is based on address and regional locations, and it's a nationwide data, so we would be able to see the relation between the virus and PM 2.5 and so on. And I will skip some slides in the interest of time. And one more thing that I would like to emphasize is, if we have data from big data, how should we present it? So that is a buzz in our industry. So in our team, in terms of meteorological, we need to look at the average temperature, the cloud volume, humidity, CO2 level, ozone level as well. So there are many different factors that play a role. And we do a validation of a hypothesis and so on. So we have a 2x2 table. Let's take a look at one of them. So we look at the color presentation to look at the correlation and so on. So many big data-based researches are also on the rise in Korea as well. So for meteorological factors, over time we'll look at the impact and study it and so on to see if it has any relations with infectious disease as well. So let's move on to COVID-19. So when the COVID-19 outbroke, the epidemiologist did evaluate the importance of the big data and the big data platform and found out that big data could play a big role. So regarding COVID-19, data is transparent and disclosed, but some time ago, a lot was in the dark. So in order to respond to COVID-19, many governments adopted social distancing, and that was done in Korea as well. At first, the impact of social distancing was not evaluated. It has not been quantified at all. But in utilization of the databases, we looked at the influenza, which is similar to COVID-19, to see the impact and consequences of social distancing, and we also looked at the mobility or the mobile volume as well. So what you see on the slide is 5 major cities, and there are some important subway stations to see the transit volume and to also see the pattern of COVID-19 and the influenza. So this is part of the very early findings, 2020 May. So we looked at social mobile volume to see if it has any impact on the infectious disease traveling around. And this slide is about the social distancing and COVID-19. We looked at the transit stations, and it looked like it has a correlation, and also it's in line with the seasonal changes. So the blue is the influenza trend, and the red is the volume or the traffic of major transit stations. But COVID-19 in the very early stages, now we have more than hundreds and more than 10,000 of confirmed cases, but in early 2020, it was less than 100 or 200 a day. We thought that it would be the end of the world if we have these many confirmed cases. So up to this point, it was hard to identify a direct relation between COVID-19. And regarding COVID-19, we're looking into many different sources and merging data with many different areas. And many researchers try to look at the internet portal site search words to see the wave or the up and down of COVID-19 and compare it with the internet search words as well. So you can see the search volume, and the COVID-19 wave has a one-week gap. So social distancing and relaxation of social distancing and volume traffic as well could be referred to help to better respond to COVID-19. So from now on, I would like to talk about the trend, or up to this point I talked about the overall trend, and now I would like to talk about the major contributions that have been made by HERA as a whole. So in Korea, following China, we had the biggest wave in Korea. So there has been some doubts over the transparency of China. That's why many researchers were looking forward to us showing our results, but in the past, we did not have an integrated database to respond to infectious disease, and it was very hard to do so. So that's why HERA and KCDC provided the confirmed case information, and based on that, the claims data was analyzed by HERA, and by HERA opening up the data set to the world became very controversial and very helpful to responding to COVID-19. So the first purpose of the researchers was to come up with pharmaceutical options, and number two, COVID-19 virus moves through the H2 receptor. So the hypertension medication, would it be safe for the COVID-19 patients to have it? So there were many different medicines served as a cure, but we also evaluated the efficacy of them. And we also looked into who is more prone to getting COVID-19. We also tried to identify many risk factors. All of the researchers did so around the world. They all were curious, but by releasing data from HERA, a big part has been resolved. So the COVID-19 platform was utilized in this study. So let's take a look at the flow chart. It looks like it's from ages ago. So the PCR test has been cross-checked with the claims data of HERA, and it was about 220,000. And I think the highest number of PCR testing on a daily basis was 800,000. So the number was not so high, but PCR testing has been done by Korea. So the test negative control, the control group was set as test negative. And as for test negative, the history and future efficacy to see if it developed into a more severe condition has been the focus of our research. So among the 220, about 40,000 was confirmed. We looked at the infectious factors and when or after infected, what are the factors for the COVID-19 to develop into a more severe case. So this is information that is very well known to all of us now. So if you have conditions of heart failure or mental disorders and so on, these patients will be more prone to get COVID-19, and after affected, they will have more probability to develop into a severe situation. But this was only proven by a single center study. But after researches, we know better that the infectious patients could be very risky. People with mental history will, after observation, have a very high severity rate. So in the beginning, I was so happy and excited that I would be able to have access to HERA's data. And I thought, my hope was all of the researchers around the world to best utilize HERA's data. So that's why we published our paper in the Korea Paper Association, and it was access code based. And if you look at this paper now, you can see the source codes as well. So all of the source codes are annotated so that other researchers could refer to it. So in the case of HERA, HERA is creating a very good environment for the Korean researchers to do research, but there might be some bumps and hurdles for international researchers to do research. So we need to continue to improve the accessibility as well. And another important thing is to think of the possible treatment options. And among the medication, if it's part of the existing medication, it would be good to do so. So all of the world tried to look for cure or treatment medicines. We also had 40 candidate pharmaceutical medicines, and when patients take this medicine, we looked to see if the severity rate has decreased after they caught COVID-19. So in most cases, most of the medicine was irrelevant to stopping the severity or the development of COVID-19. So what I mean by irrelevant is if there's an underlying condition, even though the patient is taking that medicine due to the risk of COVID-19, there's no reason for this patient to stop taking the drugs. So I think this is agreed upon from around the world. And regarding this, we also made some findings, and hypertension, diabetes, medicine did not affect the infectious rate or the severity development rate of COVID-19. And another important factor is before you came into Korea, if you did international travel, you would have taken a PCR test before entering Korea. The quarantine mandate has been implemented for a long time in Korea compared to other nations. So after release of quarantine after 14 days, did communication happen or did the spread happen? And with these tests before release, is it necessary? So that was part of our research. And based on the case of city, we created our database trying to answer these questions. And as for the medicines, many of them were prescribed based on experience, especially so for hydroxychloroquine and so on. So we tried to look at the effect and the efficacy of those medicines and drugs. And moving on, during the COVID-19, we have taken a look at the different trend of other diseases. So importantly, equally important, we need to look at the impact of COVID-19. So MPI, non-pharmaceutical interventions, have been done for COVID-19, and respiratory infectious disease also decreased by doing so. So we thought this should be presented, and compared to the predicted incident rate, we also need to see the infectious disease reduction rate as well. So that has been part of our research. And because there are less infectious diseases, we also were able to look at the impact on other diseases. In the case of COPD and asthma, the respiratory infectious worsens the conditions. So the COPD and asthma-related hospitalizations also decreased. And in the case of other diseases, COVID-19 has not been impacted so much by COVID-19 in the later half of 2021. So different diseases do not see a change in pattern, but in terms of respiratory infectious disease, there has been big impact as shown on the slide. And I would like to move on to Kawasaki disease. So the reduction in Kawasaki disease after non-pharmaceutical interventions in the COVID-19 has been shown. So Kawasaki is part of the compilation, is what some argue, and some say that it's due to environmental factors. Then during the pandemic, we have taken a look at how much the Kawasaki disease reduced, and by doing so, we will be able to better understand the reason for why Kawasaki happens. So there has been many cases of Kawasaki in Korea, so respiratory viruses could cause Kawasaki is one of the findings of our research. And regarding COVID-19 vaccinations, many studies have been implemented. So there are many concerns over the adverse events of vaccination, and in some cases, some adverse events could be very fatal. So this has been part of our research, And what needs to do first is to get a baseline, to form a baseline, to look at how much has risen after the vaccination in order to better understand and analyze the adverse events. And in terms of doing so, claims data has been very helpful. So anaphylaxis, Guillain-Barré syndrome, and so on. For these diseases, we created a baseline. So we have a new administration in place in Korea, and I would like to talk about what kind of changes would be brought about. So we do big data-based research, but we also do prediction on infectious disease, on COVID-19 as well. Social distancing impact and consequences is also part of our research areas. As you know, with the introduction of a new variant, it's as much as we have to respond to a different infectious disease. In responding to Delta and BA1 and BA5, brings about different changes. That's why the policies need to be responded or set in place in a different manner accordingly. So we have a paradigm shift in policy. This has been present in Korea. Before, we tried to cut the confirmed cases, but now we accept the confirmed cases or the spread, but we're trying to minimize the aggregation rate. And in order to do so, we look at sustainability and the cost effect. Up to 2021, the quarantine measure was to focus on the effect, to maximize the effect. So in order to do so, maximum level of social and economic loss was accepted, and this was agreed upon by the public. But after vaccinations, the quarantine-related damages have been minimized. So the level has come down, and we are trying to look for recovery of the society and also return to normalcy. So in the case of the new administration, the evidence-based evaluation is being done. So we also do prediction of waves and next waves as well, but in the case of Omicron, it was very interesting and very fruitful as an epidemiological investigator. So before, we did not have so many infectious disease patients, and vaccination was widespread in Korea, so you can see that the curves match up with each other. So based on the model predictions and based on evaluation, post-evaluation, we looked at the social effect and also looked at the social economic cost. And this is the time and age we live in. In the beginning, big data asked or answered to many clinical issues, but thanks to big data and the platforms, the past policies are backed up by evidence. Predicting the confirmed cases is important, but what is more important is to make sure that we can predict the severe cases so that we can respond to it, so that we have enough beds and facility and equipment to respond to the severe cases of COVID-19. So for Omicron, more than 2,800 beds have been prepared, and this is based on the data-driven wave prediction. Based on data and predictions, we also can decide the future policy direction as well. So the vaccination, for the vaccination, we know better what the cost would be on the social level and what kind of effects and impacts it would have on the society. So with a good functional platform, all of this would be able to be more accurately predicted. And what I would like to talk about next is what is the next variants after Omicron and Delta. And in order to answer this, we need to look at variant surveillance data. And the variant surveillance data is in the process of being integrated by NHIS data as well. So if this is able to come into the NHIS data, we would be able to have more accurate prediction capabilities. To talk about the outcome, so I think the wave or the height has been passed, and we think the next wave will come in every 3 to 6 months, which means in the early times, next December, or if it comes later, we will have a next wave in next February and March. So this is based on our prediction. So we need to make sure that we have the quarantine policies and everything prepared and we secure readiness. So the oral treatment has been secured by Korea. Some doses have been secured based on the predictions that have been made. So we need to think of our responding capacity and how much doses would be necessary to do so. And this is what we are continuing to look into by our researches. For instance, new variants could come out and the immunity system or the immune capability in our bodies are waning as well. So we need to make sure that we better predict it and we have the means to respond to it. And I think data will play a significant role in doing so. And the new administration's quarantine measures have shifted. So it's in a continuum of the previous administration. So many policy achievements. I'm not saying that this administration is undermining the previous policies, but I think Korea has been doing very well. But in the future, if we are to think of the quarantine policies, we need to think of the cost and effects at the same time. And we need to also think of the consequent social economic effects as well. In Korea, we are mandating children to also wear a mask, but that could cause educational or linguistic development damages or losses as well. So it's hard to quantify these two for comparison. So in the future, we need to make sure that we try to consider the most social and economic potential losses as much as possible. So you can see from the slide that it's very difficult to calculate the impact of NPI measures. So it does not go by scenario. We need to learn from our experiences. And in order to respond to Omicron BA.5, Korea is slowly returning into normalcy, and we're trying to make sure that we do not go back to the past and lockdowns or meeting limitations are trying not to be part of the policy. So in Korea, in order to create a big data platform, many different efforts have been put in. KCDC confirmed cases, claim cases, and hospital cases and variant surveillance cases need to come together to be integrated, to be disclosed not only to Korean researchers, but researchers around the world. And this is part of the current efforts that are being made as we speak. So for the long COVID platform, this is a project to track 10,000 people, and there is a big data of social security numbers or the key data of SSNs as well. So using the big data, or if we have a better functional big data platform, and if this is integrated to national level data, it will be very influential. So among the ones that have COVID-19, we look at the association between vaccination and acute myocardial infarction and ischemic stroke after COVID-19 infection, which I believe would be meaningful to the international society as a whole, and this is what our Korean big data platform would be able to do. And in order to do so, HERA has put in great efforts and great insight, and I would like to thank you for that. But from now on, if we are to think of other effects of MPI, social distancing, and so on, and COVID-19 tracing, HERA's participation would be significant. And if we have a better functional platform, I think it will be a good opportunity to all of us around the globe. And I would like to once again thank you for all of your efforts, all of your insight and help and your assistance to make what is possible today. Thank you very much once again.
박수 부탁드립니다.
Thank you very much for your insightful presentation.
코로나19